Thank you, Michael, for educating us and/or refreshing our collective memories about our history, essentially the foundation upon which our present system has evolved from, and for better and for worse, obviously. Somehow, Michael, you make history interesting. Thank you. Now we have part two, which we're going to just roll right into part two because we're running a little behind. Plotting the road ahead for CHCs, and so I'll invite Jennifer Rayner, who's the chair of the CACHC Research Working Group, along with Scott Wolfe, our CACHC Federal Coordinator, to share some results from the recently completed Pan-Canadian CHC Organizational Survey. Jen and Scott.
Okay, how does one follow that? Before we even attempt it, I really do just want to take a moment to thank Michael. And I think far too infrequently do we recognize some of the elder leaders within the CHC movements, those guardians of the flame that are there to remind us from where we come and where we need to go. We take some things for granted, and I think we're living in a time now when we start to realize how precious our publicly funded, publicly administered healthcare system is, and that original vision for community health centers. And I only wish there were 10 or 20 of you, Michael, and I think that's a challenge to all of us in the room, is to really nurture that next generation of guardians of the flame, because we really do need to keep alive the question, not just find the solutions, but keep alive the questions and the discussions. And we really do just want to acknowledge you and all of your ongoing support and your challenges to us, Michael. So thank you very much. I'll be really brief, and Jennifer will do the lion's share of the speaking up here, and trust me, you'd much rather hear from her than me. What I'd like to do is just introduce you to what we're doing here. On any given day, I would cringe at the thought of trying to follow Michael for obvious reasons. It would be anticlimactic. But what I think we're going to speak to this morning really builds on what Michael alluded to in terms of where we go from here, where we are to begin with, and where we go from here. And we're going to speak to what was and has been the first ever Canada-wide organizational survey of community health centers. Now, when we embarked on the process, and I won't steal Jen's thunder here by going into any more detail, we really didn't know what sort of response we would get. We were sort of putting out a beacon there saying we really need to ask for input. We need to gauge where we are. Before we talk about where we need to go, we need to find out who we are. We really were amazed at the level of response and from where response came, from community health centers in all 13 provinces and territories. I think we really need to take a minute to acknowledge that all 13 provinces and territories, we're having a conversation in every single province and territory. We now have connections in every single province and territory. I think many of us in our silos, our provincial and even more local silos, really feel encamped and that this isn't a national movement. But community health centers really do take up a much larger share of the territory, as it were, have a significant foothold across Canada, and I think it's important that we recognize it. The survey data that Jen will go into confirms that. And so from the outset here, I really do want to issue a challenge to all of us. I'll issue a challenge to individual community health centers that are autonomous, not-for-profit corporations that are cooperative community health centers, and then to our regional health authority and Ministry of Health colleagues in here that have responsibility for a portfolio of community health centers, that we need to work together. We need to work together. What unifies community health centers across the country, from one province or territory, from one town and city to the next, is far greater than what distinguishes us. And so this really is an appeal to all of us to work together on the go forward to build this national family, this national network, this national movement. And you'll see a lot of where we are. And in the conclusion of this conference, we'll talk about where we go from here. So that's it for me, and I will be joining again just at the conclusion of the presentation to talk a little bit about the policy implications of what we're, and the advocacy implications of what Jen will discuss. But without further ado, I'm really pleased and honored to introduce my colleague and CACHC board member, Jennifer Rayner. Jennifer, as many of you know, from Ontario in particular, is really an amazing resource within the Community Health Centres network. Very humbly and quietly goes about her work and astonishes us on a not even a weekly basis, but a daily basis with what she contributes to our knowledge base. And we're really thrilled and honored to have her not only as a board member, but as the inaugural chair of our Canada-wide research working group. So Jennifer will come up and walk us through what we discovered.
Thanks, Scott. Sorry.
Seems to be more focused.
Oh, on this?
But it doesn't go very well. I have a lot of trouble.
Shoot. No, I've probably turned it off now.
It's the forward button, right?
Yep.
You push this one?
Yeah.
Yeah, if you're having more trouble than I had, you may want to just ask them to move them
Okay.
for you.
Oh.
Oh.
It's not very effective.
Maybe.
I almost did that, but just in the interest of time,
Okay.
I just asked them.
Anyone have a battery?
Oh, there it goes.
Okay.
So am I not hitting it properly? Where should I be pointing? Okay, thanks. Okay, so as Scott introduced me and my colleagues on the research committee, we were a newfound group that had big goals. We had a first conversation, we had lots of ideas and lots of thoughts, but really we had to try to ground ourselves and first figure out who we were and what we did. We were, a lot of people were from Ontario, so we sort of thought, well, let's just hit the road running. But we really had to take a step, a grounding step, and figure out who we were and what we did as a sector for CHCs. So we wanted to develop an organizational survey, so we tested the survey and we implemented the survey right smack dab in the middle of the summer. So anyone that's conducted a survey knows that that's not the greatest time to conduct a survey, but we had fantastic response. So basically, CHCs were all invited to participate in this survey, and the defining characteristic of who could participate was you had to define yourself as a CHC, and we've got some definitions of what that was. We based it on the CACHC bylaws. So we distributed this survey through social network channels, our news releases, and posted it on the CACHC website. And I think we were, amazingly surprised that we had such great response. We had 213 valid responses, which to us represented about a 30% response rate. Whoops. Scott added this one. So basically, this is our CACHC bylaws. I'm not usually so detailed. Yeah. So basically, in a nutshell, what we wanted was that CHCs in the CACHC bylaws have to be providing primary health care. They have to integrate the primary health care services with health promotion activities and wellness and community health and development programs. They have to be responsible for an identified community, and basically they have to be either be governed by a board of directors or have a broader health network region having an advisory committee made up of locally representative directors. And they have to be a not-for-profit agency, and they have to provide, they have to pay for their providers on a salary. So those are sort of the defining characteristics of who was able or who was defined as a CHC in this project. Okay, so this was a slide that I really felt needed to be included because I was struck by this information. So when we were initially looking at who responded to the survey, those 213 people, I asked Scott, I said, well, how many CHCs are there in Canada? Like, what's our total N? And he said that there were 734, and I was just struck by this. So I asked that we map them out across Canada to see where they were. So we don't need to spend too much time on this slide, but I hope the total numbers across Canada show you or bring about the same awe that I experienced. So we're a really large and mighty group, and I think this tells a story just in itself, this slide. So I think Michael did a great job providing some history, and he did a much better job than I'll do with this one little slide. And I think I probably should have gone back to the 20s with that Mount Carmel site being set up in 1926. But this slide demonstrates who responded to our survey, because what we hope to do in the future is sort of learn from different elements of the data. So we hope to sort of cross-tabulate and cut the data in different ways so we can really dig a bit deeper. So this is the first glimpse at the data. So basically, it shows that we have had considerable growth throughout time. So we started in the 60s, basically as the starting point for CHCs. And I was also going to talk about Betsy and Dr. John Burry, because I met them yesterday, and I thought if you just get a chance to nab them, they were fascinating to talk about the history and what happened during that period in the 60s when CHCs were first started. So you can see here that we had a sort of oomph of growth. 29% of our CHCs that responded started in the 60s. So we have this deep foundation of history and knowledge within our sector. We experienced sort of, I thought, considerable growth during the 80s and 90s. We had 51% of our CHCs that responded that were started in the 80s and 90s, and then we've continued to grow through the 2000s, and 20% of our CHCs are relatively new, having begun in 2000. So again, just pretty high cut focus on sort of who we are as a sector. CHCs are located in big cities and urban areas. We all know that. And our survey definitely validates this. And our respondents the majority were actually from rural areas. So 62% of the survey respondents define themselves as being located in rural areas, and 9% in semi-urban areas. And I was actually surprised that only 29% of the responding CHCs described them as being in urban areas. I think this is a bit of a myth. When I work with folks from Toronto, they'll say, well, aren't all CHCs in Toronto? And I think it might be what Michael said, we only look as far as our nose pretty much. Something else that I thought was really interesting and a bit surprising for me is that the responding CHCs, only 40% of them were community governed. And we're not going to spend too much time, comparing and contrasting the different types of CHCs, but this was something that struck me as sort of interesting. A really positive piece of information that we found in the survey was that 62% of our CHCs were accredited. So this really demonstrates that we're providing high quality services and adhering to best practice standards. So we asked CHCs about their total budget from all sources and found a range of budgets ranging from relatively small budgets to larger budgets. And you can see here that the majority of CHCs are between $1 and $5 billion or $1 million. However, However, there are a handful of CHCs that have under 250,000. And again, I think I really encourage you to talk to your colleagues around the table. I was speaking to a couple people last night that they had 9 staff, but boy, were they doing programming. They had exercise programs, seniors drop-ins, food security programs. They did everything with these 9 staff. So I just think it's amazing what we're doing with this span of budgets. And you can see that almost an equal amount have between 7 and 9 million. Or 7 and 9 million. So we really span. We have very small centers up to really really large centers. We also asked about the number of income sources. So as many of you know, we're multi-funded, and you can see here that only 28% of the CHCs responded only had one income source. So for the people that have to fill out all the reports and to get all these funding sources, the magnitude of work this counts. But there's a great number of us that have a large number of income sources. So 25% of us had between 7 and 9 different income sources to make our programming work. So we asked CHCs approximately how many clients receive services from their CHC, and this slide's pretty cool because on average CHCs have about 4,070 primary care clients and 2,688 health promotion and outreach clients. So if you allow us to make a bit of a leap and potentially take the liberty to extrapolate to those 720 or 734 CHCs, which we did in fact take this leap, which is a bit weird for me being an epidemiologist. I like to, surround things in reliable data and, all the assumptions are that we've made, but we did it. And you can see that potentially 2,987,000 Canadians receive primary care at a CHC, and 1,973,000 Canadians access health promotion and outreach activities. So, I mean, it's just amazing how many people could be touched by CHCs if you sort of extrapolate this to the larger number. So many of us talk about priority populations and communities we serve, and throughout the next few days, we're going to be talking a lot about who we serve as CHCs. And this survey demonstrates that quite a few of us see priority populations. So 75% of us see what we call a priority population. So I pulled a few examples of the types of communities that we serve to describe the breadth of people that we touch. So 47% of our CHCs are focused on families and children, and these aren't mutually exclusive, so a lot of CHCs see multiple priority populations. 44% are focused on specific chronic conditions. 37% of CHCs serve people living with substance abuse and addictions. 36% see people who are Aboriginal, 35% with mental health issues, 33% frail seniors, and 28% are specifically for people living in poverty. So you can see that we see a wide group of people throughout Canada. So in addition to the breadth of priority populations, we also offer a really wide range of services within our CHCs. So every CHC that responded offered primary care services, so I don't think that's terribly surprising. But 82% of us had programming and services around chronic disease management, specifically to self-management programs. 62% provide primary care through home visits, and 33% provide primary care through street outreach or through mobile clinics. So we're really where people need us to be. In addition to primary care, a great majority of us provided harm reduction programs and mental health counseling. Something I just wanted to focus on was how much work we do around advocacy, specifically around social determinants of health. So I know I'm speaking to the converted, but I wanted to highlight all the amazing work that we are doing around the social determinants of health and advocacy work. So here are just another few examples of the types of programs that we're busy providing and advocating on. So food security, housing and homelessness, poverty, GLBT health and inclusion issues, anti-oppression and anti-racism programming. And based on the survey responses, there were several CHCs, 45%, that said they were doing other social determinant of health kind of advocacy activities. So I won't spend too much time on this, but this was our one delve into sort of the differences between community governed and non-community governed CHCs. So we found a lot of similarities, but we did find some interesting differences between the programming at community governed versus non-community governed CHCs. Basically, the community governed CHCs had more programming around and advocacy around social determinants of health and a greater diversity in programs. So they had more types of services and programs that were offered. The non-community governed CHCs had examples of these types of services, but were generally more focused on primary care, and they had some examples of specialty kind of care. So again, I won't spend too much time. I'm running out of time, and I want to give a moment for questions. We also have a huge range of interprofessionals that provide services to our clients. So the data really demonstrated that we have large interprofessional teams that work within our CHCs. So generally, almost all of our CHCs have admin teams and nurses, RNs and RPNs. And then about 2/3 have management staff, dietitians, family physicians, nurse practitioners, and social workers. And then when we get down to the 50% mark, almost 50% of us have sort of janitorial staff, which I thought was amazing. We don't have anything like that in our CHC. Medical receptionists and health promoters. About 1/3 of us have information analysts, which is positive for my plea at the end of this project. Physiotherapists were mostly found in the non-community governed. Occupational therapists, the specialists that I referred to, communication staff were about 30%. Several of us are getting pharmacists and lab technicians in our CHCs, and a few of us had psychiatrists. A very few CHCs reported that they had outreach or street health workers, midwives, research staff, or settlement and newcomer workers. So not only do we have an abundance of populations we serve and a huge number of services and great interprofessional teams, we also provide services where our populations are located. So you can really see that a lot of us have multi-sites. So almost 1 in 5 CHCs run 4 or more points of service. So my final slide. So our next step really is to take this data. We had a wealth of data provided in this survey, and we want to summarize it into a report that you can use to advocate for your CHC and for us to advocate as CHCs as a sector across Canada. So if you were at the AGM last night, you may remember that we described a few of our strategic priorities. And one of these is to make the case for CHCs and to promote our model. And the other strategic priority is to measure what we do. And so this is where I'm making my plea for you for a greater emphasis on data collection and measuring what matters. We are strong in numbers, and if we can strategize and commit to collecting data that matters, we'll be able to tell our story much better and therefore quantifiably be able to promote our model. So with this survey, we've demonstrated that we provide a wealth of services to a great deal of people who are sometimes most at risk. And, you know, we were able to tell this, but there was huge gaps in our data, and it was discouraging because I'll flip it on the positive side. 64% of us could report primary care clients, data information about primary care clients. 36% of us could report on health promotion and outreach activities. So if you flip it on the other side, there's a great number of us that can't tell that story. Only 50% of us could talk about the proportion of males and females within our CHC. So we've got some work to do. And so I hope this brief overview of the survey results will generate a lot of conversation over the next few days. I know just last night I heard about such neat programming going on in the CHCs, and I think it would do us so much good to be able to measure all of that work we're doing so we can tell the story of CHCs and start looking at our data and really be able to promote our model of care. Thanks a lot.
Thank you, Jen. We, as Jen mentioned, we definitely want to leave time for questions. And this is, I'll just say that this is one of the tighter timed or scheduled sessions. The rest of the conference is very much scheduled to allow us to breathe and have really formidable conversation. And so what we may miss in terms of questions this morning, there'll certainly be plenty of opportunity throughout the remainder of today and into tomorrow to have the discussion. Of course, the sessions are not mutually exclusive, so if you don't get to questions this morning, please reserve them. No doubt opportunities will arise to have the conversations in this room throughout the rest of the conference. So what I want to say in conclusion, again, figuring out how do we translate what we've just done into next steps as a national network, a pan-Canadian network of community health centers. Is really, I'm certain that all of you are as surprised as we have been working with the data to see some of what we've found. And in fact, that we're over 700 community health centers across the country. I know from having the conversation, as I mentioned earlier, with community health center networks and individual community health centers across the country that most folks are so mired in the immediate, so focused squarely on pressing and immediate needs without critical mass and without the ability to actually take a step back to see what that bigger picture is around community health and community health centers. That we actually see, as I said, that we occupy a significant part of the Canadian health system. I think it's actually a very fair extrapolation. I hope you'll trust me on that from the different conversations that I have and bringing in qualitative data into the mix, that we do serve around 3 million Canadians. And I'm certain that astonishes most people here and most people watching the live web stream online. What does that say? Well, to me, and I think to members of the research group and members of the CACHC board, is that we really do have a siloed country in which we're not talking across jurisdictions. And I apply that equally to us. as well as ministries of health. We really do need to take that extra time, make that effort to have conversations across jurisdictions, across the country, and we take responsibility for that as a Canadian association. What we present to you as your Pan-Canadian Community Health Centres Association, and so we really look forward to engaging you in that conversation, and this is one opportunity. There'll be many, many more. At the same time, we think it's critical that we not let policymakers off the hook. What the lack of understanding around community health centers and engagement says to us is that there really is what we call a federal fumble in healthcare, and the community health center story is one example of that. The dearth of conversation, the lack of coordination and policy frameworking across the country, across jurisdictions, to figure out primary health care, to set indicators and objectives as far as access to services, quality, and so forth, is something that we feel we really need to address as a top priority as your Canadian association. And so again today, via this conference and via a Twitter hashtag, we're calling on governments across the country to address what we are terming the federal fumble in healthcare. Now that's a new way of phrasing what we all know is a challenge within our health system. And we look forward to working with all of you, with all of our partners. The Canadian Medical Association is represented here, the Canadian Nurses Association, I know the Canadian Diabetes Association, dietitians and so forth are participating in the conference as well. We look forward to working with you collectively, and we hope that what we've presented to you here and this story is yet one more case study in why it is that we do need an active leadership, not just participation, leadership on the part of the federal government, but also concerted efforts on the part of the provinces to coordinate efforts via the Council of the Federation, and in placing pressure on the federal government to negotiate a 2014 health accord and to actually have us all at the table having these conversations about how we leverage what we've already got within the health system, how we build on 700 plus community health centers to ensure that we're actually maximizing, optimizing the existing infrastructure that exists out there, but that we're actually extending these vital services into more communities where they don't already exist. So we'll have we'll circulate a news release that's been disseminated this morning that'll provide you some more information. We'd also invite you, as far as the survey is concerned, to visit the CACHC website. That's CACHC.ca. To actually access fact sheets that derive from the research study. That'll enable you to really pay more attention to what the findings reveal and to equip yourselves as advocates at a local level in carrying forward our shared call for greater collaboration and cooperation across the country to support community health centers. So thank you very much. Thanks for letting us take up a little bit extra time. I'm where we are on the schedule if we have time for a few questions. And perhaps Michael, if you'd like to come back up. And I should say, I suppose, being a good host, if you do have a question, please go to the mic, and if you wouldn't mind identifying, just so we get a sense of who's in the room, identifying yourself and the organization that you represent.
Russ, not Rob Ford from Toronto. More of a comment than a question. I noticed the difference between the organizations that were community governed and those that weren't. And in Ontario, and maybe more so in Toronto, we're faced with the ever-present challenge of merging organizations, and there's a recent merger in Oshawa and Ajax, and there's talk in Scarborough. And I really think that defines us clearly as only a service organization. One of the differences, of course, was around the issue of advocacy. So I wonder if we have to explore the value of community-based boards as part of this whole discussion. We tend to focus on the service, the quality of service, but I think the ethos of what we are is that we are responsive to our community, and I don't think we sell that very well.
So I'm not sure if that was a question or more of a comment. I probably both. But certainly I think what we want to do is not shy away from those conversations. And that's why we do have some fact sheets on the website, and we did go into some detail around the distinctions of what we found between centers that identified themselves as community governed, either as a not-for-profit corporation or a cooperative, and centers that are the service delivery site of the Regional Health Authority or Ministry of Health. I think what unites community health centers across the country is far outweighs what distinguishes community health centers. But I think it's an important conversation to have. And community governance and the community board is one very important means of engaging community. So I you know, on behalf of the association would say that yes, I think we need to have that conversation and have further discussions about it, but we need to broaden the discussion to include community governance writ large. What does that mean? Community engagement writ large. What does that mean? What does it look like? How do ministries of health and regional health authorities, in partnership with the community health centers that they oversee and manage, engage community? How do we make that meaningful and increasingly meaningful in a variety of contexts? And that's certainly something that the research working group is discussing.
I would like to ask a question. As having been the health ombudsman for 20 years, responsible to the community boards, that was there a question in your survey on this patient satisfaction? It seems to me that we've had a magnificent review of what the professionals have and haven't done over the years. But the one thing that we did at one of my last surveys was the patient satisfaction questionnaire, and it was amazed how many people hadn't used the clinic for, say, 2 years, but yet they said they belonged there, and there was a level of satisfaction which wasn't really recordable. Obviously, they didn't seem to use the SIC system, but they certainly seemed to like the idea of the community model, and this was one of our responsibilities. The other was the high level of volunteerism that we had to involvement of our community. I think in order to keep CHCs workable, there has to be a high level of activity by the community, not necessarily just the staff. And I wonder if you'd like to comment a bit about that.
Sure. We didn't ask the question about satisfaction, and I mean, part of it was we really wanted to get a picture of who we were, and I mean, I think this is going to be a yearly survey, and we can sort of dig deeper into some of those issues after. And I know in Ontario, client satisfaction is huge to us right now. We're developing tools so we can all measure things the same way, and I think it'd be awesome if, you know, CACHC could become sort of a repository for some standardized tools, some standardized measurement around measuring client satisfaction and that sort of thing. And in volunteers, I think would have been an awesome question to ask, just to look at the magnitude of non-paid people that are working in CHCs. So I think that was probably something that we missed and we should add next time, because that would be an amazing question. So not only do we have these huge interprofessional teams, we have these masses of people working as volunteers. So a really good idea for our next survey. We did this survey really quick. So we've probably missed so much. And I think that would be great feedback if you wanted to drop me a note and send me other ideas, because that would have been something that would have been quite powerful, I think. Thanks.
Question to Jack McCarthy from Somerset West CHC in Ottawa. And I appreciated the information on the survey, and Michael, your comments fired us up yet again. I just want to, I know I'm standing in front of before people take the coffee break, which I know people are keen for, but I can't not ask you, in terms of when you look into the next couple of years at the politics that are going to be upon us federally, are you optimistic when you said in one of your slides with the NDP, with the Liberals, maybe can they form some sort of new government or whatever? What's your take looking ahead in the next, you know, in terms of how you see federal politics lining up in such a way that we can make some incremental gains? based on the players that are there now. What's your take on how we're going to do?
Yeah, I think that, well, first of all, the money is going to be better than it has been for a couple of years, likely. I mean, you know, if I were a really good fortune teller, then, you know, I wouldn't be making less than my wife is. So there you go. But I think that the money will be better. That I don't think the deficit will be erased exactly when Mr. Flaherty says, but it looks like that it will be better if we can get the Liberals and the NDP, and particularly the NDP, because the Liberals will be too shy unless the NDP can join this. The by-election in Toronto Centre right now between Linda McQuaig representing the NDP, Crisha Freeland representing the Liberals, both of them talking about the rise of economic inequality, the need to deal with that. Linda McQuaig really strong on raising taxes on rich people. Now, and so the economy will be better. There'll be less deficit. The deficit may actually be erased. And there may be the opportunity for more revenue tools. So that's all good. I don't expect that the Liberals of the NDP will go back to the ethos of the 60s around fiscal federalism. You know, I'd really have to be fantasizing big time to think that that was possible. But I do feel that that because the provinces, again, so the money's going to be better, the provinces are really, you know, they're upset with the federal government and their plans to cap their transfers to the provinces, which will result in considerably decreased expenditures. So I think that you've got the mix that's right, or right for something better than we've got now. So I think that there really is an opportunity if we can focus on, you know, well, the federal government says we don't need an accord. Mr. Harper says he never needs to talk to the premiers. What do you think, Mr. Mulcair? What do you think, Mr. Trudeau? And then I think that we have to work behind the scenes in whatever capacities we have to move those two parties. But I don't think it's going to, again, my crystal ball doesn't say that it's likely we're going to have any sort of trade-off so that they'll just run one candidate in a riding, that kind of stuff. But I do feel that there's real good reason to believe that between them they'll have the majority of seats. And then we're going to have to sort things out, right? So, and if the NDP and the Liberals are not going to talk much formally before that happens, then that gives us an opportunity and others in the back rooms, in the background, to get that conversation going. So I think with the provinces being upset, wanting some sort of federal deal, with the money being better, and with the Liberals and the NDP, they're going to, you know, whoever is in power, whether it's one of them or a coalition, they're going to have to prove that they're different than Mr. Harper. And one of the key things that I think most Canadians are thinking would represent a difference would be if they thought that the federal government had a role in healthcare. So that's my analysis, Jack. You're closer to the action where you are in Ottawa than I am to a certain extent, and I'm sure if you can grab some of the clients that use your center, they might be able to give you some good, better deep background. But I think there's reasons for optimism and reasons for us to be working together in coalition with our friends and partners to try to influence what the Liberals and NDP are thinking before the election. And then we should have things we got to have things sort of into a plan so that once they do get the majority of seats, then we can be the ones who are proposing what they should do with that vis-a-vis healthcare. So that's the best I can do, I'm afraid, from as somebody who's never given up being an optimist.
Can I follow up, Michael, with the comment? I spoke with my former MP, who was a member of the cabinet in the Chrétien government, and she said the problem in healthcare is you can't use the word national standards, because as soon as you say national standards, Quebec and Alberta leave the room. So how can we achieve this given the politics of regionalism in this country?
Yeah, it's a good question. I do feel that there still might be the opportunity to target some grants a little better, so that in fact it might well be better, instead of a new accord, to have the federal government sort of unilaterally, if you will, identify particular areas that they want to support. But when the Liberals did this, I think in either 97 or 2000 with the Primary Healthcare Transition Fund, Initially, the feds came up with like 4 or 5 criteria for projects that the provinces, that they would support the provinces to do. And then eventually it was just hacked down to 1, basically, to give the provinces the money. So I think that's an area where there may be opportunities. Quite frankly, that, what we're talking about now, that should be a national meeting within the next year in Ottawa to bring together, you know, us, people from the health coalitions, and other people who, you know, the CMA, CNA, really all sorts of others, to talk about what do we do if there's a new political equation in Ottawa. But I can't be the complete optimist on this. It's not going to be back to the 1960s when we had a federal government that's, you know, and federal parties that believed as strongly in fiscal federalism as I do. But I do think that it's going to be new faces. It's going to be a new fiscal situation, and I do think that if we can get our act together and figure out where the levers are in the Liberals and the NDP, I think we can make some progress.
If I could perhaps just follow up that and say, I think even if we were to take the hardest pessimist stance on this and say that the political landscape and outlook is dire and we can't expect much positive news from without our collective movement, that doesn't let us off the hook and diminish at all what we can actually achieve as a group together. I think we, as community health centers, need to become, as a group, and we take responsibility for this as an association, much more active advocates. I think we need to focus first on what we can do together and what we need to do together to help shape the landscape, moving from a reactionary stance to one of leadership and shaping the agenda. And so the work of the Research Working Group is an example of how we can coordinate across the country to actually begin to shape the discussion. Not begin, but carry forward the shaping of that discussion. We bemoan that we don't have electronic health records and systems in place that allow us to link data to hospitals and elsewhere that allow us to demonstrate the impact of our services. Well, what can we do without that external support and service? What can we start to do at community health centers individually at a small scale to begin to measure our impact around those things that we, you know, I think tend to agree need to be documented? Where do we start? So let's keep our eyes on that political prize and say, yeah, we've got to focus on the political environment, but what do we need to do internally to build our movement? And where do we start? How do we do that? The conversation starts with us. So, you know, that's again a call, and I appreciate that, you know, I'm self-interested in this, standing up here as the association representative at the moment, saying, you know, please be part of the movement, please be part of the conversation. But I think that the sky's the limit in terms of what we can accomplish standing from where we are without that external support. So, you know, while we may hold on to pessimism, and rightly so, I think we would surprise ourselves how many mountains we can move if we continue to make that commitment to working together and carrying forward the next steps of what the Research Working Group of the association has been doing, and other working groups that are taking shape. So.